thank you, Catapult, for this opportunity. I also want to thank everybody that is logged in. I know here in Chicago it's about 7 o'clock, and so for some of you it may be a little bit later, some a little bit earlier, but in any event, you're taking time out of your day, out of your personal life, your work life, to listen to what I have to say. And so I want to thank you for that. The title of my presentation is A Tale of Two Incisors. It's an in-office digital implant workflow story. A little bit of housekeeping, full disclosure, I am the inventor and owner of IrriGuide, one of the sponsoring organizations to this presentation. Before getting too much further into the presentation, I always like to get a general sense as to who I'm speaking to. And so if you don't mind, let's just take a couple of minutes and just answer a couple of questions. Then hopefully I can maybe tailor some of the concepts, some of the information to you specifically. Okay, I'm sure that you can see these results. So majority of you are general dentists. And so hopefully if you're thinking about entering a digital workflow in your office, or you're already tackling the digital workflow, hopefully this presentation is valid for you. Another question. So in your office, I just like to see who is placing implants, restoring implants, or both. About 14% place, 32% restore, and about 38% do both. For some of those that don't do either, again, hopefully this may inspire you to maybe incorporate something new in your office. All right, next question. And this is just polling to see what kind of digital technology you're using to date. Hey, almost half have a scanner and a cone beam, and then printing and milling just a little bit less. Well, you'll see today maybe how these new elements of technology for you may be something that you want to implement. All right, thank you for that. Before really getting into the presentation and the meat of the presentation, I just want to spend a couple of minutes talking about the British cycling team. Interestingly, from 1908 to 2003, this cycling team was a national disgrace. They were a disgrace because out of all those years, almost 100 years, the team together had accumulated exactly one Olympic gold medal, no Tour de France victories in 110 years, and it's even rumored that a bike manufacturer refused to sell bikes to the team just because of not wanting any association with this losing team. So in 2003, the team hired Dave Brailsford. And Dave Brailsford came in and he had a philosophy, he had a concept, and that concept was the aggregation of marginal gains. And he was quoted as stating, if you broke down everything that goes into riding a bike, everything that goes into riding a bike, and then improve it by just 1%, you'll get a significant increase when you put them all together. And so some of the elements, now there were hundreds, some of the elements that they improved upon were the bike seats, making them more comfortable for the riders, different fabrics that the riders would wear, whether more aerodynamic or less chafing or whatever the case may be. The team even hired a general surgeon to teach them how to wash their hands to lessen the likelihood of illness. The team traveled with their own mattresses and pillows so that they could have an element of sleep that they were comfortable with. It was just like they had back at their home bases. The team even painted their team truck white on the inside to spot any grain of dirt or sand that could potentially interfere with these finely tuned machines. Hundreds of other improvements. And it worked. Because between 2007 and 2017, the team accumulated 178 world championships, 66 Olympic gold medals, 5 out of 6 Tour de France victories. This was a successful team. And so after this successful team and their seasons, James Clear wrote a book called Atomic Habits. And not necessarily in reference to biking, but in reference to life, work-life balance. And James was quoted as stating, most of the significant things in life, and I added, and dentistry, aren't standalone events, but rather the sum of all the moments when we chose to do things 1% better or 1% worse. Aggregating these marginal gains makes a difference. So here we are tonight, after work for most people, investing your time. So my hope for you is that throughout this presentation, whether it's a new concept, a new technique, maybe an introduction to some new literature that you've never been made aware of, hopefully you can go back to your practice and your life tomorrow and find the opportunity to improve on some things just 1% better. I think in that case, I think if you can do that, I think then this seminar provides a lot of value. So this is a story. This is a story of two central incisors, and much like a story, it has chapters. And so let me just kind of introduce you to what we'll be talking about tonight. First off, I'm going to introduce you to the main characters, and then, of course, the supporting staff. The beginning of the book, the beginning of the story is a bit tedious and it's a bit slow, but I think to be complete, it's important information. So we're going to talk about how to capture data in the digital world, treatment planning, how we use that data to come up with a decision that's best for our patients, preparing for surgery. In this case, that's the work path that we're going to be following. We're going to be doing dental implants. So we need to get out of the digital world and enter into the surgical clinical world. And there has to be a transition for that. We have to prepare for that. Part of this workflow, part of the surgical course is extraction. And in my opinion, when it comes to dental implants, this is probably the most important step. We're going to spend a lot of time talking about extracting teeth because the extraction of a tooth starts the domino effect of everything that's going to come subsequent. Once you have that extraction socket, how do you manage it? What do you do with it? What do you put in it? This is an important topic to the story. And then lastly, we're going to bring the story home with fabricating the final restoration and looking at how this all comes together. So our introduction, main characters. This is Terry. Terry's 76 years old, medically healthy, and she comes to my office because she broke off her front tooth when eating. She wants it fixed. She wants it repaired. This is Richard. Richard is 80 years old, medically healthy. He slipped and broke his front tooth, number 8. Now here's where the story gets crazy. Richard is Terry's husband. And to make it even crazier, and I'm not kidding you, this happened within 1 week's time. Both Richard and Terry, both damaged, fractured tooth number 8 within 1 week's time. So our supporting cast, we can't do digital dentistry without digital technology. And so to follow this type of workflow, this type of protocol, you need to have a cone beam scanner. This is a 3-dimensional radiographic machine. An intraoral scanner. This is what replaces your analog alginate study models. A 3-dimensional printer. And then lastly, a software package to put it all together. Chapter 1, collecting digital data. So with any patient, and this is what you know, we just can't look at a single tooth. We have to look at the mouth as a whole, the patient as a whole, because there may be additional treatment that is going to affect our treatment decisions. So we do a routine dental exam. That's what everybody knows. But specific to the digital world, at this appointment, when they've presented, I will take a cone beam scan, a CBCT scan. I will also take an intraoral scan. These two elements are necessary to be able to go on to the next steps. So let's look at how this works. Terry, this is my cone beam scan work window. And for those of you that don't have a CT scan, obviously it's a three-dimensional X-ray. Therefore, you can see elements of the mouth in three different planes of space. Probably the most important plane, the one that I use most often, is a cross-sectional view through the alveolus and the tooth of interest. And in this case, you can see that this tooth, this is tooth number 8, has fractured off horizontally, roughly at the level of the tissue. Again, at the same time, I'm not only capturing a cone beam scan, but I'm capturing an intraoral scan. So the tooth is in place. The tooth is in place because she came into the office with that tooth thinking that I could simply glue it back on. Well, I can't, but I can gently lute it to be able to get that intraoral scan. Having that tooth in place provides tremendous information for planning. If she didn't have the tooth, we would have to do something digitally to recreate it. But she did, so I was able to skip that step. Richard, same cone beam viewing window, same cross-section through the alveolus and the tooth. And in this case, not difficult to see that he fractured that tooth vertically. In this case, that fracture went subgingival into the connective tissue fibers, holding it in place. That's why it's still there. So when I took his intraoral scan, again, that tooth was in place. Having that tooth in place, which we eventually want to duplicate, provides tremendous value for treatment planning. So, segue, treatment planning. We know in brief conversation that neither Richard nor Terry want a bridge, nor do they want something removable. They want a dental implant. And so the question is, the tooth is in place. Will that dental implant be an immediate dental implant, or does it need to be delayed? That's a question that we need to ask. And to be able to answer that question, several steps need to be implemented. Number one, we need to merge that cone beam scan data, that three-dimensional radiographic data, with our intraoral scan. We need to layer them on top of one another. Second, we segment out the teeth away from the jaw, and I'll show you what I mean by that. Then, once that's done, we actually digitally simulate implant placement. Once that implant has been placed digitally, we, as the providers, need to evaluate whether or not that placement is quote unquote gonna work. We'll talk about that placement criteria. And then lastly, put all this together, we can then decide whether or not the best treatment course is an immediate versus delayed. So as I go through this presentation, I want to add value to what you're learning by actually presenting literature that supports the decisions that I make. And so one of the first questions that I have is there a difference in success rate between immediate implants or delayed placements? Because if there is, and it's great enough, that may influence my decision. And so the literature that I'm going to present most of the time are meta-analyses. Meta-analyses are great because it's not an individual study with an individual protocol. It's a statistical combination of multiple studies all addressing a similar question. And this is great because adding multiple studies and accumulating that data and consolidating the data is very powerful. It gives tremendous reliable information. So the first study I'd like to present is a meta-analysis, 2019, and the question in which the authors were looking for an answer is, which is the best choice after tooth extraction, immediate implant placement or delayed placement? Exactly the same question that I had posed. The results of this study is that immediate implant placement, IIP, has a 3% increased risk of failure compared to a delayed placement technique. 3% doesn't seem like a lot, unless you or one of your patients is one of those 3%, and then it's 100%. So it's something that we shouldn't take lightly. We should consider this in our treatment planning and our decision making. Other criteria, the aesthetics, there's no difference. Bone resorption, no difference. 2022, the authors looked at a similar question, looked at success rate, and the numbers are about the same. About 3% difference, about a 3% increased risk of failure with immediate implants. And that was statistically significant. So to answer the question, is there a difference in success rate? Yeah, it's about 3%. Let's keep that in mind. Let's put that in the back of our mind as we're making decisions. So let's go through those 5 steps of treatment planning, Terry. Very first thing is need to merge our cone beam data, which is 3-dimensional radiographic data, with our intraoral scan, which again is like the analog version of an alginate or a final impression for that matter. We haven't talked about this much. This is Blue Sky Plan. This is the planning software that I use. It's free. It's great. You only have to pay when you're going to export models or export data. So you can do all this planning at no charge. This is the home menu window. Simply going to hit implant planning, import our CT scan. The next screen that comes up is all about importing an STL model. And so for those of you that are not in the 3-dimensional world yet, or those of you that are, STL stands for stereolithography. It's an identifier of a file type, of a digital file type. So as JPEG is to a photo, and STL is to a 3-dimensional model. And so our intraoral scan is imported as an STL model. And what happens is the software figures out how that intraoral scan fits on top of the cone beam scan. It does so automatically. But you can't trust it. You have to make sure that this is accurate, because if it's not accurate, every single step subsequent to this will be off. And the easiest way to check the merging process is to scroll vertically through axial cuts, and you can see on the top left of your screen that there's a green outline that tends to then follow the outline of the cone beam data. When it looks like this, you can rest assured that the accuracy of the merge is spot on. That's the merge. You've got your cone beam data, and then you've got your intraoral scan on top of it. All right, so that's our merged data. That's step 1. Step 2, as I explained before, is segmenting the teeth out of the jaw digitally. This is really cool. And so we go back to our Blue Sky plan. We simply hit the button, jaw segmentation, and this is what we get. This is a powerful image as a surgeon, to be able to see what lies beneath the tissue, what the morphology, what the integrity of that socket is. Without this type of view, it becomes very difficult to know what is the best course of treatment for our patient. Step 3 is to simulate the implant position. This is very simple. Going back to Blue Sky plan, we select our implant. We actually choose the type implant that we're using. So there's an implant library as part of Blue Sky plan. And so whatever brand, whatever manufacturer, whatever size, dimension, length, you can select that and just drop it into the planning software, right where you would want it to be. And you can move that implant to the 10th of a millimeter in any direction and to the 10th of a degree so that it can be exactly where you want it in perfect condition and position. Go back to our segmented jaw, and now we can see what it's going to look like. We can start to get to a sense as to whether or not this is a great thing to do, immediate implant placement. And so we're going to evaluate some criteria once we're at this step. And the criteria is number one, and probably the most important, and I'm going to spend a lot of time talking about this, is the buccal plate. Is the buccal plate intact? The buccal plate is so important. It's important for the aesthetics of the gum line, and the aesthetics of the gum line are equally as important as the aesthetics of the porcelain when you show it. And so the position of that buccal plate is going to affect the aesthetics of our restoration down the road. Is the interdental bone intact? What about the apical bone, the bone beyond the apex of the socket? Because it's that bone that's going to provide primary stability to our implant. Because the socket itself usually doesn't create much primary stability. And so in this case, in Terry's case, I have a reasonable expectation that there's going to be decent primary stability. At the same time, we're looking for pathology. Is there periapical pathology? Maybe the tooth had an infection, or maybe adjacent teeth have infection. And in Terry's case, they do not. So for Terry, all of this digital data collection and data manipulation, we've been talking about it for a minute here, but it happens very quick. It happens very quick. It's all part of the process of creating our plan. So for her, I'm going to extract this tooth, and this is going to be one of those cases, the successful cases of immediate implant placement. Here's Richard. We merge his data, just as described. We segment his data, as described, and instantly, I'm sure you can see that this is a different clinical picture. It's a different clinical surgical picture. We'll simulate implant position as if we're going to do it, placing it to the 10th of a degree rotation and fraction of a millimeter in position to its perfect location. And now we're going to evaluate this criteria. And this criteria, the buccal plate, number one, first and foremost, is not intact. That's a negative. This makes me feel like this may not be the best case for immediate implant placement. The interdental bone's intact, so that's great. Apical bone, the bone beyond the apex of this socket. For the position of that implant to have the long axis coming through the incisal edge that I want, and to keep that implant in the alveolar housing, there's not enough apical bone to stabilize that implant. And so my expected primary stability is negative. It's not good. There's no pathology. So for Richard, this is his treatment plan. I'm going to extract the tooth, obviously. I'm going to preserve that alveolar socket, live to play another day, and place that implant delay. That's Richard's treatment plan. So we've got through the first 3 chapters. Now we got to prepare for surgery. And again, up till now, we've lived in the digital world. We need to transition into the surgical clinical world. And to do that, the next step for Richard and Terry is surgery. We have to prepare for that. And this is what we need to do. This is what we need to have prepared for the immediate implant placement protocol. Number one, we need to print a model. We need to have a solid model because we need to make stuff on that model for that patient. Design and print a surgical guide. In my world, in my practice, I use surgical guides 100% of the time because I do 100% digital planning. And without a surgical guide, there is no way that you can replicate what you've done digitally surgically. There's no way. Not to the 10th of a millimeter or a 10th of a degree, which is what we spend a lot of time making decisions about. You can't do it. So you need to design and print a surgical guide. Provisional crown custom healing abutment. Well, in the immediate implant placement protocol, not only are you going to have an alveolar socket but you're going to have a gingival cuff. And that gingival cuff has dimension to it. It has morphology. It has a shape. And if we don't make something custom to fill that and support it, the shape of the tissue is going to change throughout healing. And again, as a periodontist, the tissue has just as much influence on aesthetics as the color of the porcelain of the crown when you show it. So we do everything that we can to manage maintaining the soft tissue contour for that tooth. Lastly, I bring every single time, especially in the aesthetic zone, like we're dealing with, an Essex Invisalign retainer. This is my contingency plan because Terry and Richard are not going to want to leave without some tooth in place for healing. And so if I can't, for whatever reason, place the implant immediately, or I don't have the primary stability to place a provisional crown immediately, I will be delivering to them an Essex Invisalign retainer. Let's see how this is done. So first off, for those of you that are new to intraoral scanning or don't have an intraoral scan, you cannot simply take this STL file and print it. It doesn't work like that because this STL file, as shown on the screen, is hollow. It's really just a two-dimensional plane that has the shape of a three-dimensional model. So it won't print. You have to print it. You go back to Blue Sky Plan, go to that module. Once that intraoral scan is in that module, you simply hit Close Model. And the software will close that model and put a base on it. Now you can see, looking inside of it, it's solid. This is something that a printer can scan. I'm going to export this. This is when there may be a fee with Blue Sky Plan, but you export it, and we're going to bring it to our printer. I use a Formlabs printer. There's a lot of great printers out there. This one's a couple years old. They're always improving technology. They're getting faster. They're pretty awesome. They have their own work window. You can choose what material you're using. You can choose what resolution to print at. And then you simply place that STL model that I just exported on the print platform and hit print. And my printer takes about 3 hours. You now have a solid model of your intraoral scan. This is what we bring to the surgical field because we don't know what we may need to fabricate in the middle of a procedure. Certainly, you're going to make an Essex retainer. Designing and printing surgical guides, back to Blue Sky Plan. Need to digitally remove the tooth. Pretty simple to do on the software. Add our implant back in, add our guide tube. The guide tube is what guides the drill of the drilling kit for that implant to that position. Outline the surgical guide, hit Create Surgical Guide, and now the software fabricates our surgical guide. Export that data, place it on our printer, hit print, and this is what comes off the printer. It's the surgical guide resin. The hole, the guide tube needs to have a metal sleeve in it to be able to support the drill accurately, gets embedded in place. And then lastly, these resins, as they come off the printer, need a final cure. They're not hard enough. That's why it changed color. So it goes through a final cure. And then all of my surgical guides have this little addition. For those of you that are using surgical guides, you may be wondering what that is. And I will get into this a little bit later in the presentation. Lastly, prefabricating a provisional crown. This also is done on Blue Sky Plan. You can see how much I love the power and the flexibility of the software. So a tooth is designed. In the software, there's no connection between the tooth and the implant, so no problem. There's a full library of tie bases. You add a tie base to the implant, you hit a button on the plan, and you get the crown that we designed merged into that tie base. And then this is what is exported. This is the temporary crown that I'm going to fabricate ahead of time for this patient. export the STL of that crown, place it on the printer, choose a different material this time. Instead of a surgical guide resin, we're going to use a permanent restorative resin, hit print, and this is what the printer makes. It needs to be assembled, so we take our tie base, take our provisional crown, and we join the two together. It's now ready to go for surgery. So lastly, every single one of my immediate implants, especially in the aesthetic zone, I have an Invisalign, I have an Essex retainer standing by, and I make them in-house. I take an Essex plastic. I have a Great Lakes Mini Star, little suck down machine. Any suck down machine will do. You simply trim that Invisalign retainer, that Essex retainer, off the model. Take whatever tooth-colored restorative material you have, you inject it into the Essex retainer, and it's ready to go for surgery. So here's our material: solid model, a surgical guide, provisional crown, and Essex retainer. That's what I have accumulated for Terry. It's a little bit different in a delayed implant placement protocol because we're not placing an implant. I don't need a surgical guide and a provisional crown, but I do need a model. And in this case, the Essex Invisalign retainer is not a contingency plan. It is the plan. That is how Richard's going to leave that day and have a tooth to be able to function with. So here we go. There's the solid model and the Essex retainer. Extraction. This is probably my favorite chapter. You know, we've gone through kind of like the mundane, tedious information. Now we're ready to work. We're ready to leave our digital world. We're ready to leave our laboratory world. Now we're ready to enter the surgical world. And so I guess to begin the conversation of extracting teeth, let's just have a little brief review of anatomy because it's important. It may change how you actually perform this procedure. Let's talk a little bit about what atraumatic extraction is. I'll talk about the luxation techniques that are available today and the instruments to aid in that. So the anatomy. I trained with Arnie Weisgold. He was a mentor of mine. And decades ago, he wrote a paper on periodontal biotype, thick versus thin. And there's been a lot that's been published on that since his original article. But there's a difference in our patients. There's a difference in the shape of teeth. There's a difference in the thickness of tissue. And there's a difference in the thickness of bone. And this is going to affect our extraction socket and how it heals. So you can't change it, but it's important to keep it in mind. Extraction sockets come with fenestrations and dehiscences. Fenestrations are like islands of bone loss overlying the root. They don't involve the osseous crest. Dehiscences do. Dehiscences is bone loss overlying the root. Can have it on the lingual surface too, but mainly on the buccal. And it involves the osseous crest. This is important to know because it may affect our treatment decisions. The facial coronal bone, this is what I really want to get into here. The facial coronal bone is the bone that exists. It's the crestal bone that exists around teeth. It's the most facial, most coronal bone of the alveolar socket. I alluded to this earlier, but it is important because it's what gives the gum line its shape and character. It influences the contour and the scallop and the position of our tissue. And again, if you see it, then it has equal importance to aesthetics as does the color and shade of your porcelain crown. And so this facial coronal bone, again, has a horizontal thickness and a vertical location. So how thick is that facial coronal bone? Like, what are we talking about anyway? So this is not a meta-analysis. This is just an observational study. 2016, where the authors looked at the buccal bone thickness overlying maxillary anterior teeth, and this is what they found. At 4 millimeters from the CEJ, which is the facial coronal bone, the mean buccal bone thickness is 1.0 millimeters. And in thin tissue, that thin biotype was associated with the labial plate thickness 1/2 of that of a thick biotype, 0.5 millimeters. That bone is really thin, which means that it's also very fragile. It's also very fragile. So another anatomical point to make is the cross-section of the socket is directly related to the cross-section of the tooth that you removed. We know that maxillary and teeth are conical-like, but they're not conical. There's asymmetries. They're not perfectly round in cross-section. There's flutes, there's depressions, there's parts of the root that's wider and part of the roots that are narrower. Having an understanding of this is important because when we talk about atraumatic extraction, which is absolutely required when it comes to immediate implant placement, it can be defined as a procedure to delicately remove a tooth while upholding the fundamental principles of preserving the surrounding bone and gingival structure. Okay, I gave this presentation to a study club that in, and a good friend of mine who's an oral surgeon stood up and said, "There's no such thing as an atraumatic extraction." He goes, "Every extraction is traumatic." Okay, he's probably right. So let's maybe just talk about the least trauma in the process of extracting a tooth. This is a case that came to me to manage about 3 weeks after an extraction. This is not an atraumatic or least traumatic extraction. That's not what we want. So let's look at the different extraction techniques. This may seem simple, but I think it's an important topic to cover. So we're going to be luxating this tooth out of the socket, and there's only a few directions that this can occur. This can occur in a buccolingual direction, but it's not hard to manage that if you move any of these central incisors or maxillary anterior teeth, if you move that tooth buccally to expand the socket to get the tooth out, it's not hard to manage that my 0.5 to 1 millimeter facial coronal bone is going to take the hit. It's going to get traumatized. It's going to rip. It's going to tear. It's going to fracture. And this is not where we want to be when we're immediately placing a tooth. This whole conversation of luxation, this may be an opportunity for you back in your practices to make a 1% improvement. Mesial distal movement. Well, sometimes that's hard when there's other teeth in place, but even if you could put an elevator into that sulcus or use a peritone, we'll look at that. There's no doubt that there's going to be some trauma, some increased trauma to that interdental bone. We need this bone. We need this facial coronal bone. We need the interdental bone. We need it to osseointegrate to our implant because it's at that location that that implant is going to take the greatest challenge. Challenge from plaque, challenge from food, challenge from brushing, trauma from forces. We need osseointegration of that coronal implant fixture level for the longevity, for the health, the biomechanics, for the aesthetics of that implant. That's why I make such a big deal out of it. Rotation. We could rotate a tooth, but like I mentioned in a prior slide or so, teeth are not conical. They're not perfectly round. They're conical-like. And when you rotate a tooth, what you're doing is you're moving a wider part of that tooth into a narrower part of the socket. And usually that's going to be in a buccolingual dimension. So it's going to be narrower buccolingually. And that wider part of that tooth has the chance, the potential of damaging that facial coronal bone. It's not a risk that I would want to take, not for my immediate implant placement. Lastly, extrusion. This is the last type of luxation that we're going to talk about, but it is extrusion. It's the only direction of movement that can be completely atraumatic, or let's say has the least amount of trauma associated with it. We want to remove these teeth by extrusion. Again, this may be an opportunity for a 1% improvement. What are the instruments available to do all these different types of movements? We have peritomes and elevators, forceps. There's something on the market today, and I haven't seen them much recently, but they're called physics forceps. We'll talk about them briefly. And then I'm going to follow up with the easy extract system. Peritomes and elevators move the tooth buccolingual and mesial distal. That's what they do. Well, these images, these illustrations were taken right off of a manufacturer's website for periotomes. And the thought is that you can put this periotome into the periodontal ligament space, sever the fibers, and the tooth will just fall out in your hand. Now, first of all, it doesn't work that way. But as you do that, I think it's pretty easy to see in your mind's eye that if you were doing this through the facial coronal bone, that facial coronal bone, which is between 0.5 and 1 millimeter thick, it's going to tear. It's going to rip. It's going to fracture. This is not a great way to remove teeth with the least amount of trauma. Forceps, again, we can rotate or we can apply buccolingual movement with forceps. Again, not hard to imagine in your mind's eye that that thin facial coronal bone, as you're moving it buccolingually or rotating it, is going to fracture. It's not what we want. Physics forceps, these are a little different. They use a rotational arc concept where there's a rubber silicone bumper that gets kind of stabilized against the buccal tissue. A beak or a jaw engages just under the CEJ, and that tooth theoretically is just going to rotate out of the socket. Again, these are images, these are illustrations off of their website. Well, it's not hard to imagine that with this type of rotation, the tooth is actually pivoting against the facial coronal bone, putting that bone at risk of fracture, tearing, ripping. So I use this system 100% of the time. It's sold and marketed by A Titan. It comes with several trays. It comes with one kind of like handle looking thing with a big knob at the end. When you screw down that knob, the jaws or the beaks of the instrument separate. It comes with drills that are a lot like parapost drills. It comes with a pin. It comes with a little ratchet. Let me show you how it works. Now, this video on the left is right off their website. I kind of correlated it to an actual clinical example, and I sped it up so that we're not sitting here for 5 minutes. And I'll narrate it as fast as I can. You have to get down to like a retained root level. You got to take off the top of the tooth if it's not gone already. You drill through the pulpal canal. You get it to the final drill size. You take one of their pins, you line it up, you size it up, you you screw that pin into that now residual root. You tighten it up against the root base. Now you take one of those trays that has the hole in it, fill it with bite registration material or some sort of impression material so that it's stabilized against the adjacent teeth, and you put in that handle looking thing with the knob. You screw down the knob and the beaks of this instrument separate, imparting a true extrusive force on that root. Pure extrusion. Pure extrusion. So let's see how this works for our main characters. Here's Terry, day of extraction. Here's the pin that you embed into that root after having drilled it with the three like parapost looking like drills. There's the tray with the hole in it. There's the pin with the tooth on it. This is an atraumatic extraction, or for my friend, the least traumatic extraction. There's no ripping or tearing or crushing of the soft tissue. There's no ripping, tearing, or fracture of the facial coronal plate of bone or the interdental bone. This site is now ready for immediate implant placement. Richard, let's see how this worked out for Richard. Same thing, placing the easy extract pin into the root, using the tray with the instrument that, I don't even know what they call it, to be quite honest. It's like the thing with the knob on it, right? That's what I asked my assistant for. Stacy, give me the thing with the knob on it. And you turn down the knob, it opens up the beak, and this is an atraumatic or at least traumatic extraction socket. Although we're not placing an implant and we're going to do a socket preservation procedure, it just aids. It makes the healing better. These are opportunities for a 1% improvement. Chapter 5. Now that we're at the stage where the tooth is gone and we have an extraction socket, we need to manage it. We need to manage it, obviously. And so let's talk about managing the extraction socket. First, I want to go through some information as to what happens to an extraction socket if you do nothing. Like, let's say we just do nothing, just let it heal. We'll get some information about that. There's some questions that I have about immediate placement and what else. Is the immediate implant placement enough to preserve that socket and preserve the soft tissue? Or are there other things that we should be looking at in addition to placing an implant immediately? And then lastly, we'll talk about socket preservation. What kind of techniques are available? What does the literature say about it? Are we really preserving sockets? So extraction socket healing, great article, 2009, systematic review. It's kind of similar to a meta-analysis. Well, they looked at dimensional changes of post-extraction sockets in humans, and they looked at a lot of them, a lot of studies. And so in general, they looked at a site where a tooth was extracted. Across all the studies that they had surveyed, the healing was anywhere from 3 to 12 months. And then they measured, the authors measured in all these studies, how much dimensional change it has occurred. And this is staggering. If you do nothing else other than extract that tooth, you will see on average 3.87 millimeters of horizontal ridge loss and 1.67 millimeters of vertical ridge loss on average. Now, the problem with that is now we may not be able to put our implant in where we want it. There may have to be some sort of compromise. And that's not kind of where we're at today. So this is good information. Just keep that in mind, that if you do nothing else with the socket, it's going to resorb, it's going to change, and it's going to change significantly. The reason is because that socket is comprised of bundle bone. And so Lindy and Arahu had described what bundle bone is. And bundle bone is a histologic term for the portion of the bone of the alveolar process that surrounds teeth and to which the collagen fibers of the periodontal ligament are embedded. It's a mouthful. But bundle bone is PDL dependent, meaning when you extract the tooth and lose the PDL, you lose that bundle bone. And when that bundle bone is almost the entire buccal plate, because remember that buccal plate may only be a 0.5 millimeter thick, you lose the whole thing. You lose the whole thing. And so it's all about bundle bone and being PDL dependent. So with immediate implant placement, some questions that I have is, okay, first, what is the level of expectation of the immediate implant maintaining the dimension of that socket should you do nothing else? Just put in the implant. That was the original thought. Put in the implant and it will maintain the dimensional width of that socket. Okay, well, we'll look at that. Is that true? Well, if not, should we be putting bone in the space between the implant and the facial coronal plate of bone? Should we be grafting it? And if we are grafting it, maybe should we be grafting the outside of the bone using a GBR technique? Should we be connective tissue grafting it? Should we be making a provisional? What is the thought of that? And what is the thought of fully guided surgery? We're going to look at some literature that answers all of these questions. So first off, when it comes to immediate implant placement and socket grafting, great study, 2015, meta-analysis, looked at the dimensional changes after immediate implant placement with or without simultaneous regenerative procedures. And what the author concluded is that when you place that immediate implant and do nothing else, you will lose width and height of about 1 millimeter. Because the bundle bone, that facial plate, that facial coronal bone is PDL dependent. You take out the tooth, there's no implant in the world that's going to keep that from resorbing. Tangent, there are some techniques out there called socket shield where you actually leave a thin little fragment of tooth in place, buccally, so as to not lose that buccal bundle bone. Well, anyway, if you just put in the implant alone, you're going to lose 1.1 millimeters. What if you put in the immediate implant and graft the gap, the room between the implant and that buccal plate, that facial coronal bone? Well, you still lose. Maybe a little bit less, but you still lose because the graft in that socket, in that space, does not preserve the bundle bone. You're going to lose that bundle bone no matter what. So immediate implants alone or with grafting, you're going to lose dimension of that socket. This is another paper answering and looking for an answer for the same question, a little bit more recent, 2022. Immediate implant placement with graft versus immediate implant placement alone. The authors kind of changed the feel of their conclusion, where they said there was 54% less horizontal loss with grafting. 54% less. They didn't say there was zero loss. They said there was less loss. And that's kind of what the other paper is saying. It's like, you may graft it and there may be less dimensional changes, but you're still getting dimensional changes. And I guess if we want to really, have an opportunity to improve on this, even just 1%, let's look at ways to maybe not have any dimensional changes. And they, not just with the bone, but looking at recession, there was less recession when grafting. Okay, same thing, not zero, just less. So I will make the point, and actually Clementini makes the point, immediate implant placement, alone or with a socket graft, does not seem to counteract alveolar ridge remodeling after tooth extraction. So if in your practices, you're in the implant game and you're doing immediate implants, please keep this in mind. Because this patient walked into my office for management. She had 5 of 6 of her upper anterior teeth extracted and placed, and an implant placed immediately at 5 different time points. This is a disaster. And it's a disaster because the surgeon didn't know that the bundle bone is PDL dependent, and you can put an implant in that socket, but you're still going to lose it. You're still going to lose it. So an alternative technique is GBR, guided bone regeneration. Now it's being referred to as contour grafting around implants. And what it is, 2018 paper, is you're not grafting in the gap, you're grafting outside of the gap. You're grafting on the buccal plate. And so the authors described a technique where the graft material is placed buccal to the facial plate and are quoted as stating, the technique is effective at resisting remodeling and resorption of the facial cortical plate. Now, you're probably still losing the bundle bone internal, but there's enough bone outside of that you're able to regenerate that facial cortical plate. Another article, 2017, by Brad DeGroot. Brad DeGroot practices not too far from me, here outside of Chicago. They wrote a paper, osseous healing around immediate implants placed using contour augmentation. And a conclusion was that buccal contour augmentation in conjunction with immediate implant placement significantly increased peri-implant buccal bone thickness. So maybe this is a place, maybe this is an opportunity to get 1% improvement. What about connective tissue grafting? Should we be connective tissue grafting these? Well, same group, Sasons and others in 2020, looked at immediate implant placement with grafting versus immediate implant placement alone. There was less resorption vertically. There was a less risk of asymmetry. So, in combination with buccal plate contour grafting, maybe this will help. Maybe this is a place where we can make a 1% improvement. Provisionals placed immediately lead to less midfacial recession because, just as I said, that gingival cuff with an immediate, it needs to be supported with something custom. You can't put on a stock component and expect it to maintain the aesthetic contour of the tissue. Guided placement. This is a great article if you have any question about how to transition from the digital world to the surgical world and whether or not you can do it without a guide. This group, 2020, looked at fully guided, half-guided, and freehand implant placement and how that ends up. Well, the authors concluded static, fully guided implant navigation surgery has the highest accuracy for transmitting the pre-surgical positioning planning to the patient. Meaning, if you're not using fully guided surgery, whatever planning you had done, there's no way you can duplicate it. It doesn't matter. So I don't know if you're all with me, if you're having a cocktail, taking a nap, but let me just ask a couple more questions just so that we can have our next conversation about guided placement. So, do you use surgical guides for implant placement if you place implants? Great. 65% of you do. That's awesome. 35%, this may be an opportunity for a 1% improvement. And we'll talk about that. We've got Gary on the line here, and if you haven't entered into the in-office digital workflow, all of this can be done with Gary. This story happens to be an in-office story, but this can all occur using your normal outside lab relationship that you have, like with Elegance Lab and Gary. Okay, next question. Are you aware that surgical guides have the potential to cause bone loss around the dental implant? I see that the question here is just a little bit different. The question is, and answer this question, are you aware that surgical guides have the potential to overheat bone when drilling the osteotomy? So if you answer the question before the new question, you can go ahead and change your answer. So it's all about whether or not surgical guides can cause or have the potential to cause overheating bone. This is astounding to me. 78% say yes. I'm glad that knowledge is out there because it's true. 2009 paper, effective surgical drill guide on heat generated from implant drilling. The authors concluded preparing an implant site with using surgical drill guides generates heat more than classic implant sites preparation. This may be an opportunity for a 1% improvement because surgical guides obstruct the flow of cooling saline from reaching the osteotomy site. It only makes sense. Now, when bone overheats, you may see catastrophic failure, but that's pretty rare, where an implant just drops out of someone's jaw. Now, University of Maryland contacted me recently, and in their residency, they're seeing a lot of catastrophic failure, especially in the anterior mandible with surgical guides. Interesting. But it obstructs the flow of saline. But you may not have catastrophic failure. You just may have a little bit of crestal bone loss. You may lose your facial cortical plate of bone. You may lose interdental bone. And who knows? We all see a little bit of bone loss around implants. Maybe that's why. So I use 100% of the time the irrigate adapter. The irrigated adapter reroutes the flow of the cooling saline through the surgical guide, providing adequate irrigation to keep the osteotomy site cool. So you're going to take the irrigation tubing off the drill and have it run straight through the surgical guide. There's a lot of other factors why we may lose bone around a dental implant, but at least with this, it's not from overheating. This is a brief little video of just how that works. The irrigation tubing hooked up to the surgical, you can see the water pumping through it. Adequate irrigation, keeping that osteotomy drill cool. So here's my immediate implant placement protocol. I'm going to extract the tooth with easy extract. I'm going to place that implant fully guided. I'm going to use a no-cut papilla flap technique for my contour grafting, and I'm going to place immediate provisional. Interesting, the no-cut papilla flap technique, what is that? Well, back in my periodontal residency, another mentor of mine, Saivian, he'd be walking around the clinic always talking about the papilla, stating, if you move it, you'll lose it. Well, sure enough, 2018, an author wrote a paper on surgery without papilla incisions and was quoted as stating, once the papilla are cut, it is difficult to achieve healing by primary intention in these fragile tissues, and scar tissue formation can be prevented if from the very beginning the papilla were not cut at all. Maybe an opportunity for a 1% improvement. So with contour grafting, as I had mentioned, this is graft material, a guided bone regeneration technique on the buccal of the alveolar plate. Well, how do you get to that if you don't cut through the papilla and lay a flap? Well, you use the no-cut papilla flap technique. And briefly, if you follow the illustrated scalpel and you go along the dotted line, you're creating the releasing incision on the palate. And once you've done that, you rotate that entire band of tissue facially. Let me show you how this works. So Terry, back to our main character. You've already talked about the atraumatic, least traumatic extraction. Fully guided implant placement using a surgical guide with an irrigated adapter 100% of the time. Here's the incision design for the no-cut papilla flap technique. Here's that tissue moved to the facial. You can see the gingival cuff has been left intact. I didn't cut through the papilla, where it's difficult to get primary intention healing. And so with this technique, I've got full view of that facial cortical plate, the facial coronal bone. Access is easy, and I can do guided bone regeneration all day long, so I do. And in this case, I use a cortical cancellous allograft, and then following the principles of guided bone regeneration, you have to use a membrane. You have to exclude all of the cells, soft tissue cells, from the area that you want to grow bone. Just let the bone cells grow in. Immediately after repositioning that flap, I've got a healing abutment in there just to keep bone graft material from going inside of the implant while I'm grafting. But at the very end, I simply remove it, put on my provisional crown, and send Terry home. This is at 2 weeks of healing. I always take a 2-week picture with the sutures in place so that people will be like, yeah, it's really 2 weeks, because it looks like there's been more healing than that, like longer healing. And I would challenge anybody that cuts through the papilla to have the tissue look like this at 2 weeks. This may be an opportunity for a 1% improvement. Because again, if you show it when you smile, the tissue has just as much importance on aesthetics as the color and shade of your crown. 4 months of healing. So we're going to pivot a little bit here. We talked about the extraction socket healing, and like if you do nothing, you're going to lose. We talked about immediate implant placements and that the immediate implant's not going to preserve that facial plate of bone. Now let's just kind of finish up this conversation on managing the extraction socket with a conversation about socket preservation. And the question that I want to answer is it preservation or is it mitigation? Is it just making it better or is it actually preserving in its full dimensional contour? Do you actually develop new bone in many of these bone preservation techniques? And if you do form new bone, where exactly is it located? And then I'm going to introduce you a novel technique, one that I use exclusively for socket preservation, that may address all of these questions. So first off, is it preservation or is it mitigation? 2019, great article. This is actually a second article that she wrote, the follow-up article. The effect of alveolar ridge preservation intervention following tooth extractions, a meta-analysis. Quoted as stating alveolar ridge preservation technique. So meta-analysis, she looked at 10, 20, 30 articles written that answered this question. Alveolar ridge preservation is an effective approach to attenuate the dimensional reduction of the alveolar ridge. She's saying this as like promoting it. Like we should be doing this because it's attenuating it. Well, attenuating isn't preservation. It's just lessening the amount of dimensional ridge preservation. So the point here is these techniques of just jamming bone in the socket is not preserving that facial plate of bone because it's PDL dependent, it's bundled bone. If you are doing these procedures, are you actually developing bone? So again, you're using an allograft or xenograft or synthetic graft material, you're putting that in the socket. Is it becoming bone? It looks like bone on an x-ray most of the time, but is it bone? Well, first off, this article, 2022, they confirmed what Avila Ortiz said, that it's effective, these techniques are effective in reducing both horizontal and vertical shrinkage, not preventing, reducing, okay. But when they talked about the amount and the quality of bone, just letting the socket heal on its own produces the best bone. Let the body do what it's designed to do. Let it fill that socket with bone. You may be saying, if you remember from the prior chapter, that if you let the socket heal on its own, you're going to lose. And that's true. But at least what's remaining will be the patient's own living bone, which is the best for implant placement. Using these techniques, and we're generating new bone, where exactly is it located in that socket? Out of all the socket preservation papers, this is about the only one that looked at this question, like where it's located. Most of them do take an average of the bone across the entire socket. This paper looked at bone apically and coronally. And in these procedures, new bone formation in the coronal part of that socket, the orifice of the socket, was only 15%. Apically, down in the depth of the socket, 63%. This is interesting because where we want the new bone is in the coronal part of that socket. I mentioned it earlier. It's the coronal part of the socket that's going to be the coronal part of the implant, the fixture level, where our restoration attaches to it. It's at that level where that implant is going to get challenged every day with plaque, with food, with pressure, with mechanics. That's the area that we want the new bone. And so sometimes we'll see x-rays of implants where there's been bone loss around the coronal aspect of that implant. Maybe it wasn't bone to begin with. Maybe it looked like bone on an x-ray, but maybe it wasn't really bone, because the follow-up part of the study is to look at connective tissue. Over half of the tissue in the coronal part of this socket was connective tissue, not bone. Apically, very little connective tissue. Just to the point, to my point, maybe the coronal part of these sockets is not bone, and it's where we want the best bone. So I'm going to introduce a technique that I developed and I use routinely. It uses a cytoplasm membrane and a little membrane fixation screw. The benefit of this technique is, number one, it maintains volume. It is a true socket preservation technique. It's It's not attenuating it. It's not reducing it. It's maintaining it. But it also allows the best new bone formation because it relies on the body's own blood clot and spontaneous healing. We just saw that study. The body is designed to do this. The body is designed to fill that socket when a tooth is lost. So back to Richard. Remember, he's a socket preservation delayed implant protocol. Here's the extraction socket, least traumatic extraction, the no-cut papilla flap technique, because I don't want to cut through the papilla. He's got a gingival cuff. I don't want to cut through that. Bring that flap over to the buccal. I put these two images together because going way back an hour or so, we talked about segmenting data. And the segmentation showed that there is dehiscences and fenestrations digitally. Well, this confirms that it is in fact accurate. There's a dehiscence that showed up on the cone beam. The segmentation data, another dehiscence, another, fenestrations. It's got the dehiscence, and then another fenestration. So it's accurate. So that segmentation is valuable. I take that little cytoplast membrane, affix it over the facial part of that socket, and do nothing else. I suture the tissue, but that little membrane with the titanium strut to it maintains and prevents the invagination, the collapse of that site. And you can see with this photograph that cytoplast membrane actually spans the dehiscence. You can see it. 2 weeks of healing, 4 months of healing. So chapter 6, moving along here. I know it's getting late. Delayed implant placement, that's part of our main character's treatment plan. And we do the same thing because now we've got a new cone beam, we've got a new intraoral scan, we segment the data. This is a different picture, right? This is a different picture of that edentulous site. Pre-extraction with the fenestrations and dehiscences, post-extraction, post-alveolar ridge preservation. Now we've got a site to place an implant into. We simulate placement, evaluate the criteria. Buccal plate, check, intact. Interdental bone, check, intact. Apical bone, well, there's enough bone there to create primary stability. No pathology. So here's our treatment plan, our new treatment plan, our updated treatment plan. We're going to place an implant. I'm going to contour graft it. Again, every time that I have an opportunity to add buccal bone, I add buccal bone and place an immediate provisional. So again, we have to go from our digital world to our surgical world. So we have a model, we have a provisional, we have an Invisalign retainer, and we have our surgical guide with the ear guide adapter. The protocol of actually doing it. Number one, how am I going to get access back to the site? Well, I recreate a gingival cuff. I place that implant fully guided. I use our no-cut papilla flap technique, and I contour graft it, place immediate provisional. Let's go to the clinic. Let's go to the surgical suite. Here's the site, day of placement. I recreate the gingival cuff. Some people call it a punch incision, but that's the cuff that is going to eventually develop into the contour of the tissue around that new provisional crown. Immediate implant placement, no-cut papilla flap technique. On the right slide, you can see the cytoplast membrane that was maintaining the volume and allowing the body to fill into that site with its own normal living healthy bone. I didn't put any bone graft in there. So I know whatever this is bone. Whereas with bone graft particles, you never really know. You never really know. Contour grafted with an Ossex Plus membrane, suturing, provisional crown in place, 2 weeks of healing, 4 months of healing. Okay, kind of wrapping things up here. Chapter 7, final chapter. It's the final restoration. Brief conversation on cement versus screw retained. I've got an opinion about this. I've got an opinion about this because not only what I've experienced in my own practice, but 2017, the impact of residual subgingival cement on biologic complications around dental implants. Quote, residual subgingival cement seems to be strongly associated with peri-implant mucositis. And I'll get a little bit more specific about this. Final subgingival cement. It seems that some of these temporary cements, and I'm not like talking about temp bond clear, talking about like a zinc oxide eugenol temporary cement, does not seem to be correlated with this. Some of these temporary cements that are resin-based, that's not what we're talking about here. Temporary zinc oxide eugenol cement is not correlated with implant mucositis. Everything else is. So I don't do cement retained restorations anymore because of this concept, the angled screw axis concept. Prior to this concept, if you wanted a screw retained crown, the access channel to the head of the screw would have to come through the cingulum or the lingual surface. Well, oftentimes in the anterior maxilla, because of the buccal concavity and everything else, sometimes you can't get the access channel through the cingulum or the palatal surface. So what did we do? We made custom abutments, and then we made crowns to fit over the custom abutment, much as if it were a tooth. And then we started cementing them permanently, and then we started seeing peri-implant mucositis. Well, now with the angled screw axis concept, whether that long axis of the implant and the screw axis channel would otherwise come through the facial or the incisal edge, we can now reangulate it to the palatal. And this concept is what allows screw retained restorations to be used majority of the time. Screw retained restorations are clean. The tissue loves it, not having that cement subgingivally. Okay, how do we take the impression? Well, depending upon your implant, there's a scan fixture or scan body. And so let's see how this works. Terry comes in with her provisional crown. Crown comes off. Look how clean that gingival cuff is. Look at the contour of that because of the immediate provisional. If you put on a round stock healing abutment, it wouldn't look like this. The scalp of your tissue would not look like this. You'd have potentially an aesthetic failure. You put on your scan body, your IO flow, you scan it. In this case, I veered away from the in-office because it's a central incisor, and I needed the artistry of a ceramist to make it. So you send it off to Gary at Elegant Labs, and this is what you get back. It becomes predictable. Richard, same deal. The gingival or the subgingival or the gingival cuff, well healed, well shaped to be able to mimic the contralateral tooth. Put on an IO flow, scan it. Again, a lot of character to the central incisor, far beyond what I can manufacture in-house. So I rely on a ceramist. Well, you just send them the digital file. You send it by email, whatever, it doesn't matter. And your lab, like Gary, he'll have master ceramists to create something that creates symmetry to the opposing tooth. And so, kind of wrapping things up, Terry, Richard, both went through the procedures, a different workflow, but ended up at the same spot. And Terry and Richard finished and lived happily ever after. The end. And so at this point in time, we can open this up to question and answer. And I'll be monitoring that. Lisa will be monitoring that, and we'll see what kind of questions we can get here. Okay, so great photos. Thank you. What camera are you using? A Nikon. Name of lab? This is Naoki Aiba. He's out of Monterey, California. He's an oral design lab, and he's spectacular with ceramics. AJ, what is the extent of bone loss you would be comfortable using only with the cytoplast, and when would you want to use cytoplast with the bone graft material as well? So 100% of the time, AJ, if I'm using that technique, the cytoplast has enough rigidity. Let me put it this way. In the guided bone regeneration technique, the only reason to use a bone graft material is to support the volume of your membrane. So back in the day, Gore-Tex had titanium reinforced membranes. You could cut that membrane, you could shape it with your thumbs, you could attach it into place, you could leave it empty, and it will fill with bone. So to answer your question, If I'm using the cytoplast workflow, I don't use a bone graft. If I'm using an Ossix type technique, that Ossix is flimsy. There's no rigidity to it. So in that case, I use an allograft. Who sells the extract system? That is sold exclusively by A Titan. I just talked to the owner of A Titan. They usually do a lot of vendor stuff. I know for a fact that they're going to be at Greater New York. They're usually at Chicago Midwinter, but it's a.titan.com, something like that. At what point in time do you remove the membrane? I allow that socket to regenerate through spontaneous healing for 4 months. At 4 months, they come in, CT scan, move on. I've had to wait a little bit longer on big molar sites, but any of these anterior sites, 4 months. 4 months. Does the extract system work for curved roots? Yes. So I've used it on multiple root teeth, like first premolars, upper first premolars. I had a lower premolar that had a hook root, and I knew that I was going to struggle to get that tooth out. So I used the Easy Extract. It literally popped it right out. It was amazing. So I guess it depends on the curve, but slightly curved roots, no problem. Did you remove the titanium strut before placing the second buccal graft on the delay? Yes. So in the delayed protocol at 4 months, when I go back in, I remove the membrane and place the implant at the same time. Yes. So did I remove the titanium strut before placing the second buccal graft on? Yes, I did. What are your timeline preferences on extraction bone graft and then placing implant? I wait 4 months. I wait 4 months. Here's the other thing. You start jamming stuff in that socket, it takes longer to heal because now the body's going to have to try to get rid of it. 4 months in the upper anterior, spontaneous healing with a blood clot, 4 months. Thank you, Dr. Jackson. Excellent presentation. Thank you, AJ. Do you use chronica sutures or non-resorbable? Diana, 100% of the time, non-absorbable, and I'll tell you why. Because for that chronic gut suture to dissolve, quote unquote, it requires inflammation. I want to minimize inflammation, and this may be a 1% opportunity for improvement, right? I use Ethelon, 5-0 Ethelon, almost exclusively for everything. The other thing is, like, you don't really know how long that chronic gut suture is going to like stay like structurally intact for, right? Like, and with some of this grafting stuff, you don't want your incision line to start opening up too early. I know with my non-absorbable, I know exactly when it's going to come out. So non-absorbable, 5-0 Ethelon. Do you have to have screws to fixate the membrane if you're not putting them? Yes. You cannot take that cytoplast membrane and just lay it over the top of the socket and think it's going to stay there. It will move around and get infected. So yes. All right.
There were a couple of questions in the chat. One was, which allograft do you use?
So the first question, what bone graft material? So first of all, it's an allograft. It's not a xenograft. It's not a synthetic. It's an allograft, so it's human donated. Cortical cancellous, and the manufacturer, that for me doesn't really matter. So I usually just buy it through my implant supplier. Okay, so most implant companies also have a regenerative line, so I just get it from them. But it's a cortical cancellous mineralized allograft. But again, it doesn't really matter because in a guided bone regeneration technique, there's no osteoinductive activity of any of these bone grafts. They're there just to help support a membrane. So I don't like xenografts like the BioOs. They just like hang around too long. If I did have to use it, that's why I use an allograft. Lisa, what was that second question again?
Is cytoplast membrane resorbable?
It's non-resorbable. So it's actually, Gore-Tex, they don't make membranes anymore. It used to be an expanded polytetrafluoroethylene, basically an expanded Teflon. Cytoplast is the same thing, just not expanded. What does that mean? I don't know. It's a manufacturing thing, but it is a non-resorbable membrane. So I guess that's it.